it can be a problem. Miscompliance with the timeline of tests, they just take it the way they do. Although I was happy to see Omsk experience because they said retest is what they do on the 21st day. On that same day, the child gets counseling from CF specialist. The problem of early discharge from the maternity,
То, о чем я говорила.
because in this case the child can just fall out from the screening program. And you know what, during sweat probe the children are not examined by pediatrics, and in a number of cases this leads to a delayed diagnosis. During the follow-up stage, we have unjustified hospitalization for the children. When the child is diagnosed against screening, he is sent to the federal center. Should be calculated the dose of ions, and he has to be administered Dornasa. And very often he comes back from the federal center by having intermittent growth of Pseudomonas aeruginosa, etc. We keep talking about it. We want to be heard. In case the baby has no manifestations, no symptoms, for some reason they don't administer therapy, although we know that pathologies begin when the child is still unborn, and we set the diagnosis to start the therapy. In a number of cases, they don't do vaccinations to these children, although the neonates that were diagnosed against neonatal screening program have to be vaccinated. As for trypsin, we need to keep in mind that it identifies all the children with CF, but it's not informative 6 weeks after. So we need to follow the timeline. And the contamination of the samples with feces of the neonates, often it leads to the false negative results. And very often it is caused by the contamination of blood samples with feces. And that's why when the operators are persistent and they check one blood stain after another, they can detect it. Don't forget about sweat test. Control the sweat discharge speed, and we use nanoduct system, and the rate 200 and above, 300 and above are not eligible. Also keep in mind that some mutations are associated with normal or marginal values of sweat test, and we need to holistically evaluate all the results, the entire clinical picture. Here are a few clinical cases. This is Meconium ileus. The diagnosis was only determined at the age of 9 months, positive sweat test, 2 mutations, and we have polyresistant Pseudomonas aeruginosa. This is the home baby delivery in Moscow, no neonatal screening done. At the age 1 year, 9 months, the child was diagnosed. IRT 68, it's very low, although the norm, if it were 70, this baby wouldn't be in this positive screening. And sweat test, only 54, 56 millimole, high pancreatic elastase. At the age of 4 months, they did the sweat retest, and the child was referred to DNA diagnostics, and they identified the mutation. He was diagnosed at 4.5 months. If the cutoff level was not accurately chosen, this child would fall out from the screening program. This is another case. Remember, several years ago, we reduced the norm for conductivity. In the past, it was 60. Now, this is the baby whom we skipped because the sweat test was 60 to 66. We recommended to examine this child at the age of 1 year old, but at the age of 7, he developed the pseudo-Bartter syndrome and was hospitalized. You know, sweat indicators may change during the first year of life and they may increase. So we need to monitor these patients closely. This is something I mentioned before, 4.9% according to the registry data over 2017. Now false positive false negative results, 7%, and we need to analyze them. I'm not going to dwell upon the mistakes. They are clear. If we compare with the parameters of other countries, of course, 7% is a lot. 4.9 is the frequency compliant with the European and African countries, but 7% is too much. What we're trying to achieve is to examine the child at 35th, but not later than 56th day of life. And what are the ways of doing? We need to revise our screening algorithm, train our specialists to develop the exchange of knowledge and communication between the specialists, and we need to focus put the focus on the outpatient unit. We identify a lot of clinically stable children who don't need hospitalization. We have 30 years of experience of doing it, and we urge you to do the same. Thank you very much for your kind attention. Thank you so much, Victoria Davidovna. I think that your presentation is an illustration of what Jörg Barben was saying, that neonatal screening is not a laboratory test. And it's not even the first stage of clinical study. It's examination. It's neonatal screening is a system of medical care to a particular group of patients. And, you know, exchange of knowledge and right organization of all the steps of this screening is the guarantee of success. This is what we're trying to achieve, right? Because we need to identify the patient as early as possible. We want to have clinical manifestations as late as possible, life expectancy as long as possible, and quality of life as good as possible. This is the purpose, and this is the purpose of the screening, and our government is spending a lot to yield an effect in here. So I believe that the proposals you have made are really reasonable and about training, about enhancement of communication at different stages. Unfortunately, we don't have any questions yet, and we are a bit late in time, so I want to give the floor to Olga Adinokova from Tomsk. She will speak about the outcomes of DNA tests to improve neonatal screening and early detection of CF. Olga Nikolaevna, please, the floor is yours.
Запустите на полный экран.
Да. У нас какие-то проблемы с подключением?
Do we have problems with connection?
Нажмите показ слайдов и начать сначала. На своей презентации, которая у вас сейчас открыта в данный момент, чтобы развернуть ее на полный экран. Нажмите и включите свой микрофончик. Вот я вижу, собственно, вашу презентацию. Теперь включите микрофон и видео. Ольга Николаевна. Внизу, в зуме, слева микрофончик и видеокамера. Включить звук, включить видео. Да, я вас вижу. Все, вывожу.
Скажите, видно презентацию, да?
Can you see my slides? Yes, we can hear you, we can see you.
Знаете, у меня не получается, я не знаю, где переводить.
You know, I can't scroll.
Уважаемые коллеги, я представляю Институт медицинской
Dear
генетики.
colleagues, I present the Institute of Medical Genetics of the city of Tomsk, and I will tell you about the DNA test system that we introduced to enhance neonatal screening and early detection of CF. The importance of the problem. Here I want to say that until now, the DNA diagnostics in the official protocol was not envisaged as a mandatory step. But when we began screening in 2006 in Tomsk Oblast, and having got experience as we examined the patients with this pathology in our region, we thought that we should include the DNA screening of the neonates of high risk alongside with the accepted screening scheme. I want to say that the molecular diagnosis of CF is done since 1991. So from the very start in the well-known scheme, at the stage of high IRT test values, we invite the patients to our center, and after the next mandatory study, we also did the blood sampling for molecular genetic studies in order to test the CFTR gene. Neonatal screening of CF in Russia and in Tomsk Oblast officially started on the 1st of June 2006. And on that particular day, we had the first patient with CF born on the 1st of June 2006. And we saw there the high values of immune-reactive trypsin, and then we did a retest of his blood and DNA diagnostics, and the accurate diagnosis was made in the end of the 3rd week of the life of this patient. This confirmed the accuracy of our method, and we decided to continue doing so. The approach that we use for DNA testing for CFTR mutation is given on this slide. We examine the frequent mutations of CFTR gene. And I have to say that in different years, we examined and tested various spectrums. In the beginning, it was 20 mutations. Now we examine over 50 mutations. We examine, if needed, large deletions and duplications. In case it is needed we do sequencing, gene sequencing, and SGS sequencing. On this slide, you can see the testing for 50 most frequent European mutations. We do it with the Elucigen kit. You can see the range of mutations that this kit helps us to identify. We like this practice very much. I want to point out that here, and with this kit, for every patient, we have 2 reactions. One reaction with primers for all mutant variants, the so-called reaction A. In reaction B, we have primers for the same sites, but the ones that comply with the normal fragments of the gene. So when we see the mutations, so the blue specific peaks are identified, while the analysis of normal fragments shows us if it's heterozygous or homozygous mutation. And also the analysis of the normal fragments is very indicative to identify some other possible gene defects. You can see here how we detect 2 mutations in one of the patients. There are 2 mutations here, one blue peak, F508, and another one is a deep intron mutation, the so-called soft mutation. The same kit helped us to quickly and promptly identify another mutation that was not earlier described. This is a fragment of an analysis of a normal peak of CFTR gene, and this is the same analysis on the patient. The profile analysis showed deviation in 4 peaks. Each peak is split into 2, and an additional peak is 5 nucleotides shorter. The analysis showed that they are all attributed to the 3rd exon, and we thought we can assume there's a deletion in this exon, and sequencing of this exon only helped us to identify a deletion that is located on the margin of the 3rd exon and 3rd intron, and it covers from the 2nd nucleotides in the 3rd intron to the 6th nucleotide. In this case, we can see the classical splicing sequence, and of course, this disrupts the splicing of the 3rd exon. You can see here the mutation we identified the gene AC in the relevant loci. We had 2 neonates with this mutation in Tomsk Oblast. Here you can see the mutation. The sequencing identified a mutation with the terminating codon in the 22nd exon. 1 nucleotide replacement leads to the formation of stop codon. These are all neonates. We, in case of need, can use MLPA analysis. Here, for example, in 1 neonate, we saw the duplications in 7th, 11th, 8th, 10th, 9th, and 11th exons. The results of the work help us to do the evaluation of main mutations that we identify. The main mutation F508 was encountered in 61% of cases. Next mutation over 9%. This is a large deletion of 2nd and 3rd exons. 3 mutations were identified with the incidence 3%, and all the other mutations in total amounted to 11.3%. These are quite rare mutations. Besides, we had 2 cases of 2 large intragenous duplications affecting 7th to 11th exon, and another patient had a duplication from 6th intron to 11th exon. In this way, we have identified 95-point-something% of mutations, and less than 5% of the mutations remained unidentified. All in all, cystic fibrosis was diagnosed in 1 out of 6,000 neonates tested. And I have to say here that whether or not we skipped some cases during the analysis, over this time, we detected only 1 case that we skipped. I showed you this picture already. This is a clinical case when the patient was taken to the doctors at the age of 2 years old and something. He had a soft mutation of F508. We looked at the screening results. Everything was normal there. For that mutation, as we found out, this is not the only case of skipping. According to the literature, this is something to consider. The main part of the first time diagnosed CF is contributed by neonatal screening, and as a rule, these patients are the first cases diagnosed in the family. Something new we do in our practice is additional selective screening in pregnant women. Implementation of neonatal screening in the families that don't have the relevant history of disease is possible as we detect some markers as they do ultrasonic study on the 19th and 21st weeks of pregnancy. This is something we implemented in our clinic in 2019. We know that hyperechogenic intestines during the ultrasonic study are one of the best known ultrasonic markers of the inborn and hereditary diseases. Besides, they are present in 50 to 75% of the embryos with cystic fibrosis. The echographic markers were divided into three groups: absence of the visualization of pancreas, combination of no visualization of pancreas and hyperechogenic intestines, and hyperechogenic isolated intestines. Considering these markers, we suggested to do neonatal diagnosis to exclude any chromosome pathologies of the embryo and also cystic fibrosis. And here you can see two examples of pregnant women screened. Patient K, during ultrasonic study, the pancreas were not visualized. The intestines were hyperechogenous. The loops were expanded to 6 millimeters. No other defects. The test showed that the fetus had F508 deletion. Second case, the patient had heart rhythm failure of the embryo of the fetus. The intestines were hyperechogenous, fragmentary, no other failures. Two mutations identified: F508, the most frequent deletion, and a large deletion of second and third exomes. All in all, in the first group, as I mentioned, with one marker of no visualization of pancreas, we detected only one patient with cystic fibrosis. In the second group, we detected two patients with cystic fibrosis, I mean the fetus, with two mutations, F508, and also a mutation of two deletions of second and third exomes. In the third group, where there's only echogenic intestines, we haven't identified any CF patients. I want to say that these both families didn't have history of CF disease. Two families made a decision not to prolong the pregnancy. One woman decided to give birth, and the diagnosis of cystic fibrosis was confirmed in the neonate. In this way, the implemented selective screening of pregnant women contributes to the reduction of birth rate of the patients with cystic fibrosis. Now, to plan a healthy child, this prenatal diagnosis is available in our center. Conclusions. As a result, we implemented the algorithm of neonatal screening for cystic fibrosis in Tomsk Oblast with a mandatory DNA test. This ensures effective diagnostics and reduces the time of final diagnosis and allows to start early treatment. Prenatal practice of cystic fibrosis detection, if there are specific markers on the ultrasonic study of the fetus. This is practiced in Tomsk Oblast. Cystic fibrosis was detected in 1 out of 6,000 neonates. The considerable share of the families with detected neonate patients in the future had prenatal diagnostics. Thank you very much. This much from my side. Thank you very much, Olga Nikolaevna. I have a question. Did I understand you correctly that in the group of neonates with a prenatal pathology that you detected on ultrasonic study, the absence of pancreas was a more informative criteria as compared with the hyperechogenic intestines? Yes, you are absolutely right. Fetal hyperechogenic bowel as as an independent marker was not informative, but no pancreas. Yes, in this group, we detected one case of CF, fetal CF, but in the group where there was a combination of fetal hyperechogenic bowel plus no pancreas detected, there in this group we detected 2 patients. So I would say in this group the efficiency rate was even higher. As for the standalone fetal hyperechogenic bowel, we didn't have any case confirmed, although this is the marker that we normally consider to be the most informative, right, as compared with pancreas. In the literature, at least, in our practice as well. Well, the second group is also with hyperechogenic bowel, right? Yes, thank you very much. You know, of course, the detected mutations that we identified are all severe mutations. We cannot assume whether in cases of more mild mutations, we would have the same reasons to do the prenatal diagnostics, whether or not we will detect at the prenatal stage if these are more mild mutations. Nevertheless, in 2019, for example, the detection of neonates with cystic fibrosis was 0 because we prevented due to prenatal screening with statistics. These were 2 cases, 2 fetuses to be born in 2019. And you know, when we have 12,000 infants born, 2 is the incidence of cystic fibrosis, so we prevented it in 2019. Thank you very much. We give the floor to Maria Vakharlovskaya. She will represent the group of authors and she will share the experience of St. Petersburg on how to deploy the strategy of DNA diagnostics in neonatal screening. Hello. We can hear you. I cannot turn on my screen. I need Olga to leave her translator. Yes, Olga left and now we can see you.
Ольга Николаевна, завершите, пожалуйста, демонстрацию своего экрана. Вот, можете начинать.
Спасибо большое. Еще раз добрый день.
Good afternoon once again, dear Presidium, dear colleagues. Thank you very much for the opportunity to speak and to present our data at the Congress on Cystic Fibrosis. Cystic fibrosis strategy of DNA diagnostics in the algorithm of neonatal screening experience of St. Petersburg. I do not want to repeat the previous speakers. A lot has been said about the importance of the strategy and the relevance of neonatal screening, especially the one for cystic fibrosis. But anyway, we thought it is important to say once again that conducting neonatal screening means that we need to constantly analyze the to do the SWOT analysis and always keep in mind the theoretical benefits and possible risks. We also agree with the fact that the protocols of neonatal screening for cystic fibrosis should be developed in a way to reflect the healthcare system capacities and the clinical picture of cystic fibrosis in that region. A lot has been mentioned about the strategy of neonatal screening of cystic fibrosis, but in our opinion, it's important that starting from 90s in Europe and in the US, the algorithm of neonatal screening included genetic analysis. whereas according to the national consensus of 2019, the Russian gene diagnostics is playing an important role, but we can diagnose without gene test as well. On the right side of my slide, you can see the key comparisons of two crucial strategies of neonatal screening with genetic tests. And you can see very well here that the inclusion of the gene test in the algorithm of neonatal screening increases the efficacy of neonatal screening and reduces, in many cases, the time to diagnosis, which positively impacts the prognosis and course of disease. Despite the general guidelines on the neonatal screening, in every region they do it in their own way. And on this slide, you can see the algorithm of CF diagnosis within the neonatal screening program that we do in St. Petersburg. I'd like to draw your attention to the fact that despite the absence of mandatory DNA diagnostics, in the algorithm of neonatal screening, we try to do the DNA test of most frequent mutations among neonates from the first blood stain that they normally take in the maternity hospital. In the it's not a secret that this situation is very often accompanied with marginal values of IRT, and probably IRT values here are not so relevant as in other situations. And also in case we have the cholestasis syndrome among neonates, or in case we want to exclude other pathologies, we need to keep it in mind as well. In 2015, we had an important event happening. The chief doctor of Center of Medical Genetics recommended to implement the gene sequencing for 3 nosologies. The main authors of this project were Yulia Churumova, our doctor, and the head of biochemical laboratory, Natalia Vokhmyanina. I have to say that as we speak about the design of this pilot project that we conducted in parallel with our generally accepted neonatal screening, the role and place of NGS was changing during the project. If in the beginning NGS sequencing was done in all the children who had the elevated IRT, because of the little practical use that I will tell you about later, at first we decided to do the NGS sequencing only in those neonates where they had the elevated persistent levels of IRT. But after a while, everybody decided that NGS sequencing is more optimal to be used as a final step of diagnostics after we did all the steps of screening and DNA diagnostics as well. And in this way, according to the results of the pilot project that lasted for almost 4 years, from 2015 to 2019, all in all, we examined 254 patients. More than half of the children didn't have any genetic variants of cystic fibrosis, and in the future, according to the general diagnostic algorithm, they were not diagnosed with cystic fibrosis, and 17% from all the researched children had some clinically relevant genetic variants, and in the future, unfortunately, these children were diagnosed with cystic fibrosis, and they are not all treated in the St. Petersburg CF Center. On this slide, you can see the variance among the diagnosed children, 43 patients, and I want to say that only 23% out of them had mutations identified, and they couldn't have been identified by any other gene analysis, gene test. Another cornerstone for any sequencing is the detection of the genetic variant in combination with a normal allele. We had 29 patients of this kind in our project, and during the analysis, we divided them into two groups. Group 1 are the children with normal alleles in combination with one of the frequent mutations of CFTR gene, but in our opinion, it took us more efforts to work with another group of children where the genetic variants were identified, but the information about them is either not present in the open sources or is controversial or scarce. They are highlighted in green. These are the genetic variants where we can see the information about these variants in CFTR2 database. So according to our data, about 3% of the researched patients during our project, out of them 3% had genetic variants of unknown clinical relevance. This, of course, causes some difficulties for clinical interpretation, diagnosis, and definition of their condition and strategy of examination and treatment. As I finish the presentation, I can say that on this slide you see the comparative results of the practical results of NGS sequencing. In first case, the sequencing was done in all children because of the elevated IRT. In the second case, NGS sequencing was done only to the group of children where we realized that we are not looking for a black cat in a black room, because our first task is to identify the sick children. And you can explicitly say that when NGS sequencing is done as a final step of diagnostics after the DNA analysis, it is of more practical use. One more component without which it's hard to talk about genetic testing at all is the economic component. It is not a secret that genetic tests, gene tests, are quite expensive, and it is not every laboratory, especially a clinical one, that can afford it. Moreover, as far as the genetic examination during neonatal screening is concerned, time is an important factor, because the sooner you confirm the diagnosis within 30 days, not later, the earlier the better. Moreover, in some cases, the factor of time is becoming even more important when the child is severe in the ICU, and the ICU specialists, of course, want to see the faster and more accurate response, and the information about speeding up the screening after day 21 is not what makes them happy about. So when we're talking about costs, we try to group the costs in the following way. Of course, one of the constituent parts of costs is the equipment of the laboratory. Of course, it varies depending on the scope of work and possibilities, but if we do the approximate estimates, it may take 20 to 50 million rubles to equip the laboratory. The second big thing is having the right human resources. This is as important and challenging as the lab equipment. And you know, the gene test is the kind of test when the result depends on the good work of a number of specialists. You can see the list of them on the slide. The only thing I want to say is, and perhaps this is more important for clinicians, that not every genetic doctor is by default a specialist in interpreting NGS sequencing. So in this way, according to the rough estimate, if we do the sequencing with the low capacity machine with a minimum production rate, when during one run we can examine about 20 patients, the cost of one sample is around 20,000 rubles. The reason why I was mentioning time as a crucial factor is because the screening is the most vulnerable thing when they want this final answer from us as soon as possible. Probably if the process took us longer, the cost would be lower. In this way, one of the key requirements to the neonatal screening is the readiness of the healthcare system to implement the new technologies, and it's not so easy to do, of course, as it may seem. In this way, during the pilot project on the inclusion of NGS sequencing in the neonatal screening program, we realized that it's not a feasible routine diagnostics method at the IRT method. Its NGS is highly resultative as a DNA diagnostics for rare mutations of CFTR gene. It's reasonable in terms of being a step in diagnostics, and economic parameters are very important. Sometimes they are the decisive factors for this study. And last but not least, I wanted to say, and maybe it's not quite all right to say it, but the genetic gene analysis, gene tests, as different from other tests, is finalized not when we can write a lab report and give a response. We finish it when we give the answer to the family, and we try to give the answer to the family when we do the counseling with them. And there's a whole range of problems here, not easy ones at all. We try to group them, and we have the following chapters: medical issues. We always speak about the need to finish the examination. For example, when the child has one mutation and we have to confirm and finish the examination. And again, we need to tell the parents that it is quite, let's say, expensive. We need to do the counseling with the family for the sake of planning of next pregnancies. We have to obtain the informed consent form for the gene test from the family. The status of the carrier of a minor. Again, there's an experience of some countries where the detection of genetic variants and defining the status of the carriers until the age of adulthood is not conducted. Raw data, data storage, and one more problem.
Как-то не всегда она очевидна, это психологическое консультирование семьи, потому что сам факт...
There's one more challenge, which is not always obvious. This is the psychological counseling of the family. You know, in some cases, psychological counseling is very important because this whole process of the test is quite stressful for the family. And our experience shows that sometimes it requires not only some explanations from the medical genetics, but also it requires a psychologist. I would like to finish the brief representation of our data. Thank you for your attention. Thank you very much, Maria Viktorovna. We have to finish our this talk. But I have to say that implementation of DNA diagnostics in the screening algorithm, on one hand, is showing us some unidentified problems, but on the other hand, we have some other problems like a lot of under-examined children, refusal to take part in step 1, step 3 of the screening, false negative results, and also something I mentioned today is the sweat test cost is so high that it can compete, that it can often compete with the cost of DNA diagnostics. We need to keep it in mind.
Получится у нас в Московской области провести такое пилотное исследование. Ну, надо опыт наш увеличивать,
I think
чтобы мы могли четко для себя понять, нужно нам менять алгоритм скрининга.
we need to evaluate all these factors to understand whether or not we should change our screening algorithm. A few words to conclude. Thank you very much to Maria Viktorovna for the brilliant analysis, including ethic and psychological aspects of this problem. I have to say that implementation of NGS in the screening system is a hot topic now, not only as applied to cystic fibrosis, and we see the first publications comprising the experience of international groups that, as applied to other groups of hereditary diseases, used NGS, and at least today for the genetic diseases of metabolism, they say that it's good to do the phenotyping diagnostics of biochemical markers as compared with NGS diagnostics. We had the most recent guidelines of the European Society of Human Genetics. They relate to the, some questions there are overlapping. The main thing about these guidelines is that whatever is implemented should be considering the healthcare system in every country and its funding. Because depending on these different technologies will be either acceptable or not acceptable for the society. So the pilot projects must be conducted. Even in a multinational country like ours, in logistics, in volumes and structure of population, different programs can be efficient. But even in a large city as St. Petersburg, they have vast experience.
Скрининга будет тоже полезен для того, чтобы сравнить, оценить не только чувствительность и специфичность, но и экономическую эффективность.
I think economic efficiency should be compared, for example, with St. Petersburg and Moscow, etc. There's something else that we were discussing. I was alarmed by your high figure, high rate of false negative results. After IRT2 test and sweat test, less and less people opting for it.
И это понятно, что люди получили шокирующую информацию, и с ними надо уметь работать, чтобы...
I think that we don't work well with the people because it's not only upon the genetic service that the speed of diagnosis and start of treatment we depend on, but also the way the patients take the information they get. This should be a road with two directions. I think it's an interesting symposium. I want to thank everybody. We finished today our symposium, and we will have the very last symposium with interesting presentations as well. So we wait to meet you at the next meeting. Thank you so much.